very interesting. And I really, just to follow up on the last point, I think you've touched on something very important in how we define what is fatal, because you're absolutely correct. We're all fatal. Once we're born, we're all fatal. But to try and put legislative structures on words and definitions can, as you say, in your experience, legislative changes can take a very long time. And I can't think of the name of the case in Britain some time ago, but legislative changes that were being discussed and debated in the High Court meant a long period of suffering for a woman and her child. So I think, just to say here openly to everybody, I think we have to be careful about the words we use when we're advising about the type of legislation we want, but mindful of the stuff that you've pointed out. And you've pointed out some really serious issues that we have to grapple with. And one of them that struck me was that some women present late with crisis pregnancies in the cases of severe handicap or severe disability in a fetus because of poorer socio-economic conditions. And in that case, I think we have to be very mindful of this, because within the parameters of looking at how we structure some kind of legislation, we have to remember that the Citizens' Assembly did very passionately want, in fact I think they had to add this into the discourse, that socio-economic conditions had to play a major role in forming the outcome of their discourse. But just want to take up a couple of points, and it's a bit on the same vein as Kate O'Connell, Deputy Kate O'Connell asked you about feticide. So an injection can go straight into the heart and stops the heart beating. It's lethal, but would you say that in doing so, it's lethal, it paralyses the fetus, it kills it? Is there evidence that it causes pain? And could you expand on the discussion about pain, because this is often used in a very emotive way to argue against the treatment of pregnancy in this way. Another important point I'd like you to expand on is that a lot of the options that might involve women taking options when they've had a scan at 20 weeks, they might need a follow-up one very quickly within 5 days. That often isn't available to them in Ireland, which puts them at a big disadvantage. And although they may go to Britain and have that, they then need the follow-up care, discussion, conversation, the important sort of emotive and physical and medical understanding of everything that's going on with them. And would you agree that because they can't get that at home, where they're surrounded by family, by supports, that they're particularly disadvantaged by being forced out of Ireland to have that sort of care? Yeah, I think maybe that's it. But I think that when we are talking about this issue, we have to think about the cruelty. If those who use the term cruelty to a fetus or cruelty to an unborn child, and they often talk about it in terms of a baby, we have to think very clearly about the cruelty to the woman also, who's been denied access to this kind of reproductive health. And I would just like you to comment on those.
Thank you, Deputy.
Okay, so first of all, if we talk about late diagnosis, I mean, one of the other things is some women who present, some conditions only present late on. And the other case that I gave you in the papers, microcephaly, whereby the brain isn't growing normally, usually only presents after 24 weeks. So even if you have a history of having a previous baby with this, then in many of the cases, you have a 1 in 4 chance of having another baby affected in the same way. And we would have to scan those women all the way through their pregnancy. And sometimes their head size appears normal until you get as far as 28 or 32 weeks. And then suddenly it becomes apparent that the baby has microcephaly. So I think that is an important thing. With regards to fetal awareness and pain, there has been Royal College of Obstetricians and Gynecologists studies on this, looking at the literature, and on a regular basis that they come out with definitions about this. And what they said last time was that the evidence that the fetus can and does experience pain is less compelling, and accordingly the benefit of administering analgesia is less evident, while the risk of practicalities of so doing remain. So on the basis of first do no harm prior to the procedure described in this report, analgesia is no longer considered necessary from the perspective of fetal pain or awareness. And so the previous report had suggested that we should give analgesia to the fetus in case the fetus felt pain, but then after that it was suggesting that it wasn't. I'm not an expert on fetal pain, but that's the Royal College of Obstetricians and Gynecologists position. With regards to are Irish women disadvantaged? I think very greatly they are. In the UK, not long ago, there still is a shortage of sonographers, but in the UK, many units stopped doing their 20-week scans, but we've had to train up and many of our midwives now who perform ultrasound scans to get a new cohort of professionals to do this, and I think it should be something that's available to everyone. One of the difficulties we do have is with women, ultrasound is dependent upon how large you are, and overweight women, in overweight women you get less good views, and so women are often brought back for a second look. And so when we talked about doing it between 18 and 22 weeks, if you do it at 18 weeks, then there's a greater proportion of women that you have to bring back to have a second look. So you end up doing more scans overall. And that's why most people settle for around about 20 weeks as their best evidence.
Just can I have time for one last question? That's on the issue of post-mortem on the fetus. And I notice that this is often recommended for medical information for future pregnancies. And that sometimes the information that might result from that post-mortem can be difficult to, for a woman to get her head around, to accept, to absorb. If there are issues about her own anatomy and her own possibility of conceiving in a normal way and being able to bring their birth to full term in a normal way. So the sort of follow-up that's needed from various specialists and that isn't available to her in Ireland, would you comment on that, the need for the possibility of having a post-mortem on the fetus to advise for the future health of the reproductive health of the woman?
So I think that the post-mortem provides her with two opportunities. One is people often want a reason why something has happened, and this gives an opportunity to finish that chapter and allow people to move on. And that's very important, and information can be difficult to hear sometimes, but often it's better to have the information. In the second part, that it's essential that if you're going to impart, if you hear this story and how bad it is, and it's quite distressing and you've lost your baby, and then if you're told, just go away and don't know it, is this going to happen again or is it not? And, we might be able to do the post-mortem and say, there's a 1 in 1,000 chance this will happen again. Or we might do the post-mortem and say, we found some other differences in the baby as well. And that means that it would appear that the baby has a syndrome. And that syndrome has a higher recurrence risk. And so now you have a 1 in 4 chance, for example. And then people will obviously view those two things very differently. And they can make decisions about their future reproductive life in the knowledge of what's there. And then in the service here at the moment, this is a time when you would be able to direct ultrasound scanning at a much higher risk group.
Thanks very much.
Thank you. So now we're moving on to the next speaker.